Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. So in this case, we have a 4-year-old white male presenting with a limp for 3 weeks. The patient was healthy up until about 3 weeks prior to admission when the mom noticed he was limping. The limp has worsened over these past 3 weeks, and the patient is now limping throughout the day. For the past week, he has also had low-grade fevers up to 100.5 with a decreased appetite. He has not been as playful as usual. The mother remembers the patient jumped off the bed and landed funny about 4 weeks ago. The entire family, including the patient, had the flu about 2 months ago. Mom also states the patient has been having accidents and been wetting the bed at night off and on for the past 1 to 2 months, despite being toilet trained for the past 1 year. Past medical history includes eczema that has been difficult to control since he was 18 months of age. Mom has tried several different creams that her primary doctor prescribed, but none has made a big difference. Patient has also had recurrent otitis media with drainage for the past 3 to 4 months, requiring multiple rounds of antibiotics. His birth history was unremarkable. His immunizations are up to date. He lives with his parents, a 6-year-old sister, and they have no pets at home. Family history includes a maternal grandfather who had an MI at age 74, an uncle who has Crohn's disease, an aunt with psoriasis. Travel history includes going to Cancun about 6 months ago. Physical exam reveals vital signs, a temperature of 38.1, heart rate of 100, respiratory rate of 24, and a blood pressure of 92/60. In general, he is in no apparent distress, sitting quietly in mom's lap. On skin exam, he has several areas and patches of eczema that are on his cheeks, arms, and legs. Some of these areas have excoriation, while some of these areas of eczema also have some petechiae. HENT, his head is atraumatic normocephalic, pupils are equal, round, and reactive to light and accommodation, and extraocular muscles are intact. Tympanic membranes both appear gray and retracted. The throat is with no erythema and no lesions in the mouth. Neck is supple. Lungs are clear to auscultation bilaterally. Cardiac, there's regular rate and rhythm. Abdomen is benign. Extremities, there's no clubbing or cyanosis, no joint swelling. The right tibia appears swollen and tender to palpation. On neuroexam, the deep tendon reflexes are 2+ in the lower extremities. Cranial nerves are grossly intact. The patient does limp when he is walking, and he favors that right leg. So to summarize our problem list, we have a 4-year-old male coming in with a worsening limp for 3 weeks. He's had a fever for 1 week, decreased appetite, and decreased activity. He landed funny about 1 month ago. He's been wetting the bed for the past 1 to 2 months. He had the flu about 2 months ago. He has difficult to control eczema and recurrent otitis media with drainage over the past 3 to 4 months. There's a family history of Crohn's disease and psoriasis. He has areas of eczema and excoriation with petechiae, and he has right tibial swelling and tenderness to palpation. So in this case, we have a child that is coming in with a limp. So let's talk about the differential diagnosis of a 4-year-old child coming in with a limp and how you would evaluate that patient and what is on the differential diagnosis. When I think about a limping child, there are 6 rules that I think about as I'm going to consider how to approach that child. Rule number 1 is related to the duration of the limp. How long do you think a child should be limping before you get worried about them and have them evaluated? It's actually a very short time. If a child is limping for more than 12 hours, it is considered an emergency. So rule number 1 is that it is an emergency and they need to be evaluated if they are limping for more than 12 hours. And that's because there are some things on the differential diagnosis that are very worrisome and that you don't have a lot of time to think about and to sit on and to wait. So you need to address that child if they're limping more than 12 hours. So it becomes an emergency. Now many times kids are going to trip and fall and hurt themselves, but usually what happens is that just after a little bit of time, you distract them and they forget about their pain and they're no longer limping. So that means that usually then it's a benign type of process. But if it goes on and they continue to limp and it's more than 12 hours, then they really need to be evaluated. So that's rule number 1. Rule number 2 is related to the joint that is usually involved when they come in with a limp. So when a child comes in with a limp, which joint do you think you have to assume that the pathology is in? Rule number 2 is that you assume it is in the hip. When a child comes in with a limp, usually there's something going on in the hip. So that is rule number 2. Rule number 3. When a child comes in with a limp, how often do you think parents give you the history that their child had some sort of trauma preceding the onset of the limp? It's actually very high. Most parents are going to say in like 95% of the time that their child had some sort of trauma before the limp started. Because they know when they come in to be seen by the doctor, they know the doctor is going to ask, what was the little child doing when the limp started? And the parents are always thinking about, what was my child doing when the limp started? And inevitably, they are going to be able to think of something that the child was doing that put them at risk for hurting themselves. They were jumping on the bed, they jumped off the couch, they did something that potentially caused the trauma before the onset of the limp. So most of the time, parents are going to give a history of trauma preceding the onset of the limp. So rule number 3 is never believe that history of trauma that the parents are giving you. Now I say that kind of jokingly because obviously if they give the history that the child fell down the stairs and they have an obvious fracture, then that's going to be relevant history. But the point is that you shouldn't go down the wrong path and assume that the limp is related to that trauma history that the parents are giving and get fooled and not look into the other things on the differential diagnosis. So rule number 3, never believe the parent's history of trauma. Okay. Rule number 4 is related to how to approach a child with a limp. Many times when you ask a child where it's hurting, they'll point to a certain part of their lower extremity. And children have a hard time localizing pain, or they have referred pain. So actually when they have something going on in their hip, they might actually say that their pain is down their leg and in their thigh, or maybe even in their knee, because children have a hard time localizing pain and they have referred pain. So rule number 4 is what I call the above and below rule. Above and below, meaning that wherever you think the pathology is in, think one joint above and one joint below. So wherever the child is pointing, or based on your exam, there seems to be some tenderness in a certain area of the lower extremity, think of one joint above and one joint below. Because again, children have a hard time localizing pain and they have referred pain. So the rule number 4 is the above and below rule. Rule number 5 we'll come back to as we go through the differential diagnosis. And then rule number 6 is going to be also related to the workup once we've created our differential diagnosis. So now let's go back and think about the differential diagnosis on a child coming in with a limp. So we have this 4-year-old child who is limping. So there's different entities on the differential diagnosis that we can start to consider. And I break it up into categories. The first category is related to some of the urgency and the emergency of diagnosing the cause of a limping child. That's going to be under the category of infection. So let's talk about infectious causes. So infection. So there's a few infectious causes that you have to consider urgently, right? And what is the most urgent thing you have to think about? for which you have to diagnose, and you basically have 8 to 12 hours to make the diagnosis and start treating the child. That is going to be the diagnosis of septic arthritis. So septic arthritis is a huge consideration on a child coming in with a limp. Now, usually a child with septic arthritis will have other symptoms other than just a limp. They'll usually have a high fever. So if you have a child that has a fever of 103, 104, and they look sick and they look toxic, and they're not bearing weight on their lower extremity, so it's more than just a limp, they're actually not wanting to bear weight. In that type of presentation, you have to think about septic arthritis. And actually, at the door, as you are going in to see the patient, they will give you some indications that they might have septic arthritis, because again, the history will be a high fever of like 103 or 104, and they will look sick, they will look toxic as you go in to examine them. And as you look at them from the door, as you're going into the exam room, they're going to be lying in bed in a frog-leg position. So they're going to have the hip that's involved, because it's usually the hip that they're going to get the septic arthritis in. They're going to have it in a frog-leg position where it's going to be flexed and externally rotated. And that's an involuntary response when you have fluid in your hip to take pressure off the femoral head. So the child is going to be lying in the frog-leg position based on the leg that is involved, and they're going to have the fever, and they're not going to be bearing weight. So you have to think about septic arthritis in that patient. When it comes to septic arthritis, the most common organisms that you worry about are going to be bacterial causes, and that basically involves Staph aureus and group A strep sometimes, but usually Staph aureus is a big consideration in septic arthritis then. Okay, so now the next category of infections that you have to think about in addition to septic arthritis is going to be other musculoskeletal type of infections. So now we have the joint of septic arthritis, and then we can go on to the bone and think about osteomyelitis, right? So you can have an infection in the bone and have osteomyelitis. Now you can have osteomyelitis in a long bone, right? So they come in and they have it, in their femur, or they have it in their tibia, so they have it in a long bone. Or they can actually have osteomyelitis in other bony areas as well. So let's say, for example, you have a child coming in, and they are coming in with right hip pain, and they have pain when they walk, and they're limping, and they point to the right hip. So how do you apply the above and below rule when a child is coming in with right hip pain? The below is obviously going to be into the femur or into the knee. So you think about osteomyelitis of the femur, or something else going on below the hip space or the hip joint. So how about above the hip? How do you apply the above and below rule above the hip? So if you think musculoskeletal, above the hip, you think further up into the sacroiliac area, and actually further up into the spine as well. So that's one area that you actually have to think about osteomyelitis, is that they can actually have a vertebral osteomyelitis, in which they are coming in with more hip pain on the right side potentially, and that they are limping and that they are not walking properly. So they can actually have a vertebral osteomyelitis as their presentation of a limp and inability to walk. So I think that's a consideration as well. And that gets back to our rule number 5, which is when a child is limping or not walking properly, you always have to make sure that you check their back. So always do an exam of the back. So always check their spine, palpate and percuss along their spine to make sure they don't have a vertebral osteomyelitis or a discitis that is causing them to have referred pain into their lower extremities, into their hip area, or giving them trouble in walking in general. So check their back. That is rule number 5, because they could have a vertebral osteomyelitis. Other infections that you might think about, staying on the thought of right hip pain, and the above and below rule. So we talked about musculoskeletal causes of pain from above the right hip. And then how about other causes of right hip pain that can be referred as you apply the above and below rule. So if you think above the right hip again, what are some other things that might give you pain in that area? And you might have an infection that's causing that pain above the right hip. So if you think about it, there's other things that you have to consider. And a big consideration on a 4-year-old child coming in with right hip pain and not walking, when you apply the above and below rule, is going to be related to an appendicitis. So they can actually have an appendicitis that maybe has ruptured or caused a psoas muscle abscess, and that is causing them to have right hip pain and the inability to walk and limp. So another consideration is some sort of abscess, like a psoas abscess or an appendicitis or a ruptured abscess or something like that, that is causing them to have right hip pain and limp and inability to walk. So I think that's another consideration as well then. Okay, so these are some of the things that you have to consider under infection. And like I said, septic arthritis is the emergency that you have to think about. And the next category that you think about is actually what I like to call post-infection. So in this category is the most common reason for a child to come in with a limp. So what is that diagnosis? What's the most common diagnosis and the common reason for a child to come in with a limp? And that is going to be something called transient or toxic synovitis. Transient or toxic, some people call it synovitis. This is the most common cause of a child coming in with a limp. And it's most likely post-infectious from a recent viral infection. So a child will have some sort of viral infection, a URI or some GI symptoms, and that viral infection causes a kind of a reactive arthritis, and they come in with a limp where they have a little bit of fluid in their hip related to that post-infectious type of process. So transient synovitis by far is the most common reason for a child to come in with a limp. And again, this usually is post-viral, and you will get that history where they had a recent viral infection, maybe a little bit of fever and URI type symptoms, and now that has resolved, and now they come in with a limp, and they have this transient synovitis. So this is the most common cause of children coming in with a limp, is going to be transient synovitis. Now the problem with transient synovitis is that it's a diagnosis of exclusion. So you have to think about all the other things on the differential diagnosis, and then rule those out, and then come up with the diagnosis of transient synovitis. And this could be from any type of viral infection, any type of viral process. Specific viruses can do it, or just non-specific viral infections can do this as well. So that's the most likely cause of a child is going to be something benign, like a transient synovitis from a recent viral infection. So that's something you have to think about, but you have to also consider other things on the differential as well. Okay, and that is transient synovitis. And now other post-infectious type of processes. You can also have a reactive arthritis similar to this from a recent viral, instead of a viral infection, you can have it from a bacterial infection. And typically we call that more of the reactive arthritis, and that is usually not post-viral, but that's usually more post-bacterial. So they have some recent bacterial infection. And again, this is different from a septic arthritis, where you actually have bacteria in the joint space. This is that you had a bacterial infection somewhere else in your body and caused a reactive arthritis. So one of the most common bacteria that can do this is a group A Strep Pharyngitis. And we know that group A Strep Pharyngitis can give you reactive arthritis as a simple type of process, or it can give you the full-blown complication of rheumatic fever, where you have the arthritis as part of rheumatic fever. And that's all, again, post-bacterial then. So that would be another category of post-infectious causes of a child coming in with a limp. And then other reactive arthritis, like I mentioned, could be group A strep, but you can also get reactive arthritis from different GI bugs as well. So things like Salmonella or Shigella and the different GI bacterial infections can also give you a reactive arthritis as well. So that's something to keep in mind and consider. And then other causes of post-infectious type of limp. Another thing that has to be considered are things like Lyme disease. We know that arthritis can be part of Lyme disease, and it's more of a post-infectious type of process. So that's something to consider. And occasionally, you can actually also see it with mycoplasma infections as well, where you get a reactive arthritis after a recent mycoplasma pneumonia. So that's something to consider as well. Then. And in this category, basically what happens is that you have an infection somewhere in your body, a viral infection or a bacterial infection or some sort of other infection, and the immune system gets overactive and reactive to that infectious process, and then the post-infectious process takes over, and your immune system causes you to have the transient synovitis or reactive arthritis related to different infectious causes. Okay, so the next category then, so we have infection and we have post-infection, and now the next category I like to think about is your immune system is revved up and is overreacting to an acute infection, but in some patients the immune system is always overreacting and is always revved up, and that can cause limping, and you can have more chronic type of processes that are related to collagen vascular disease and autoimmune type of processes where your immune system is always overactive then. So then the next category would be kind of autoimmune or collagen vascular disease. So those are another category that we can think about. And in this category, we have the common things that we think about, like JIA, juvenile idiopathic arthritis, or even like lupus. Sometimes can present with limp and joint pain as well. And then in pediatrics, there's a couple other diagnoses that you have to think about that can present with a limp. So one other entity, which is thought to be immune-mediated, causes different vasculitis, and they can present with a limp where they have arthritis, but also then they'll have other symptoms. And classically in the diagnosis I'm considering and talking about right now is in addition to the limp, they might have a rash, a purpuric type of rash that's palpable on their buttocks and lower extremity. They can also have hematuria and a glomerulonephritis as part of this entity in this vascular process. And the process that I'm thinking about and referring to is HSP. Hanoch-Schönlein purpura can present with arthritis as well. And the big components of HSP, in addition to the arthritis, is the rash, and then you get a glomerulonephritis and a nephritic syndrome, and then you can also have abdominal pain as part of an enterocolitis, and that can actually set you up for intussusception. So there's different type of presentations of HSP, arthritis and a limp, and joint pain can be a manifestation of that as well. And in that same category, in addition to HSP, if you have a child that is limping but also has had 5 days of fever, has had a rash, has some edema of their hands and feet, has some oral mucosal changes and eye changes, that entity that you would think about at that point would be Kawasaki disease, because that can also cause a vasculitic process and therefore a limp as well. So that's another diagnosis that you have to think about in the autoimmune collagen vascular disease category. Okay, moving on to the next category after autoimmune and collagen vascular, I like to think about ortho. So let's just talk about different ortho causes of a limping child. So some of the common ortho causes could obviously be trauma, right? They suffered a fracture and coming with a limp. But trauma in pediatrics, we always break up trauma into two categories, right? So it could be accidental, where a child fell and sustained trauma and a fracture and things, or it could be non-accidental trauma as well, so some sort of inflicted trauma or abuse type of situation as well. So accidental and non-accidental trauma is always a consideration in pediatrics. So the child could just have a fracture, have some sort of trauma, and ortho causes of the limp then. Okay, other ortho causes. So let's say you have a 6-year-old or 7-year-old child coming in with a limp, and they're pointing to their thigh or even their knee, and you do a range of motion, and they have limited range of motion of their hip. And then let's say maybe you do an x-ray and it shows some flattening of the femoral head. There's a specific entity that you think about in that age of a patient, of maybe a 7-year-old presenting with those type of symptoms, and that would be the entity of Perthes disease, right? Leg calf Perthes disease, or just short Perthes disease, which is basically an avascular necrosis of the femoral head. Nobody knows what causes it, but it's a primary avascular necrosis of the femoral head, in which a child comes in with a limp. Typically, the vignette will be, or the case history will be 7 to 9 years of age, limping, pain maybe in their hip or radiating down to their thigh or their knee, limited range of motion, kind of slow progression over several days or weeks, and then you would make a diagnosis of Perthes disease. Okay, so now let's think about other causes of limp, maybe in older kids, right? So let's say you have a 14-year-old adolescent that is coming in with a limp, and they're a little bit on the overweight side, and they're coming in with, again, thigh pain or knee pain, and you do an x-ray, and it shows that the femoral head has slipped off of the epiphysis, and there's some dislocation of the femoral head. So now you made a diagnosis of another orthopedic process that can present with a limp, and can present over several days or several weeks, and that is something called Skippy, slipped capital femoral epiphysis, where the femoral head slips off of the epiphysis, and typically the history will be an adolescent patient who is a little bit overweight, comes in with some chronic kind of hip pain or leg pain and is limping, and has a Skippy. For Skippy, you always want to check the other side and do an x-ray of the other side, because up to 30% of patients will have bilateral Skippy, and the treatment is surgical, so you want to know if one side is affected, you want to know if the other side is affected as well. So that would be the other entity that you would think about. And then let's say on the differential, one more thing from an orthopedic perspective. Let's say you have a 16-year-old soccer player or cross-country runner, so does a lot of physical activity, and they come in and they are pointing really to their knee, and kind of over their tibial tuberosity as the location of the pain. What disease process are you thinking of in that situation? That's going to be a child who has Osgood-Schlatter disease. So that's another consideration as well, but that's usually an older child who is running and very active. So Osgood-Schlatter, where you have pain over the tibial tuberosity from overexertion, and basically resting it, and ibuprofen is going to be the treatment of Osgood-Schlatter disease. So these are some of the orthopedic type of processes that you have to think about in children with a limp based on their age. The last category you want to talk about is heme and onc, and we'll kind of divide these up. So heme, there's some hematologic things that you have to think about with a child with a limp. If the child was African American, and there was maybe a family history of sickle cell trait or sickle cell disease, that's one of the big things you have to think about is sickle cell disease presenting with a limp, and bone pain and infarction and vaso-occlusive crisis, so that would be a consideration. And then under heme, another consideration is, let's say you have a 2-year-old male that comes in with a big swollen knee after he tripped and fell, and has a huge knee and swelling around that area. The thing that you would think about in that patient from a hematologic process would be some sort of bleeding disorder, particularly hemophilia, presenting at that age with hemarthrosis and bleeding into the knee and bleeding into a joint. Typically, you won't see those symptoms until they are a little bit older, where they're able to run fast enough and fall hard enough to be able to have bleeding into the joint. So hemophilia would be the consideration in male patients coming in with limping and large swollen joints. And then moving on to the last category, we'll talk about oncology. So if you have a child that's coming in with low-grade fevers, and maybe some like petechiae and some bone pain, you think about some bone marrow involvement from a malignancy perspective. So major consideration is going to be leukemias, like ALL especially, where they can have bone marrow infiltration and they come in with bone pain. And I think this is a very major consideration in a child coming in with a limp, because up to 25% of patients who have leukemia will have their initial manifestation with something musculoskeletal like a limp. Not 25% of patients who are limping have leukemia, but 25% of patients who do have something like leukemia, their initial manifestation will be something like a limp. So that's a major consideration in children coming in with a limp, to make sure they do not have leukemia. And then a couple other entities that you have to think about that can involve the bone marrow. Another tumor, solid tumor that kids can get at 2 to 3 years of age. Maybe they have an abdominal mass, and then they're coming in with a limp. The other malignancy to think about in that situation would be a neuroblastoma. Neuroblastoma can metastasize to the bone marrow and cause you to have bone pain and limp, so that's a major consideration. And then there's another entity that can cause bone marrow involvement, and that is something called Langerhans cell histiocytosis. Is another entity that can cause you to have bone marrow infiltration, and you basically have histiocytic infiltration of the bone marrow, presenting with bone pain. Okay, so this is our differential diagnosis of a child coming in with a limp, and there's a lot of things to consider at this point then. So now the question is, what type of workup should we do on a patient coming in with a limp? The workup of a child with a limp can be very elaborate, given all the things that we have to consider on the differential diagnosis. Now we know by odds the most likely diagnosis is going to be a transient synovitis. Like I mentioned before, that is really a diagnosis of exclusion, so we need to rule out a lot of other things. And that's what our workup is going to be based on. How do I rule out some of those things and eventually come up with the most likely diagnosis of transient synovitis? Just one comment, I hate limping children, because there's so many things that you have to think about on the differential of a limping child, and inevitably they come in at the end of the day when you're finishing your clinic or finishing your shift, and then they come in and now you have to figure out what to do. So my approach to a limping child, when I first see the patient in the clinic or in the ER setting, is I do a little bit of a workup that will help me rule out some of the more worrisome things. And that's going to be related to rule number 6, is going to be what type of workup you do on your initial presentation for this child. So when a child comes in with a limp, I always do a few things. I always do a CBC because I want to see what is happening on their overall blood count. You might think the reason I do the CBC is to diagnose a septic arthritis. And that's not the reason I'm going to do a CBC. I don't really care what the CBC and the white cell count is going to show if clinically I think they have septic arthritis. The reason I do the CBC is to make sure that they don't have any type of cytopenia on their CBC, because I'm worried about a leukemia or some bone marrow infiltration and a malignancy in that child presenting with a limp. So that's why you do the CBC, to make sure they don't have pancytopenia or a bicytopenia or anything on the peripheral smear like blasts that would suggest some sort of malignancy. So I always do a CBC on a child coming in with a limp. Then I also do a sed rate and a CRP as inflammatory markers on that patient, because if their sed rate and CRP is elevated, then you worry about infectious things, or maybe autoimmune collagen vascular type of processes. So I always do that workup. And if they are febrile, then I always do a blood culture if they are running a fever. Now usually in transient synovitis, they don't have an acute fever. They may have a history of a fever, but that fever has resolved. But if they still have a fever at that point when they're coming in with a limp, I always do a blood culture to make sure they don't have something like an osteomyelitis, in which the blood culture might be positive. And then I always do x-rays above and below. Above and below where I think the pain and the pathology might be in. So if they're pointing to the thigh, I'll do the x-ray of the knee and also the hip. And if they're pointing to the hip, then I always do the x-ray of the other side, looking for symmetry, and get a bilateral hip x-ray then. So this is the initial workup that I order on a child coming in with a limp. So when I'm seeing them in the clinic or the emergency room, I will send them to get this blood work and the x-ray. Before I send them, I will give them a dose of ibuprofen, and give them the dose of ibuprofen in the clinic or in the emergency room, send them off to the lab, send them off to x-ray. They come back from x-ray, they come back from the lab. The x-ray is negative for any type of fractures or any other pathology. The blood work comes back normal, the CBC is normal, the SED rate and CRP are normal, so everything is normal. The child comes back, and by then the ibuprofen is usually kicked in, and now the pain is much better, and they might not be limping anymore, and they might be walking normally, but they have significant improvement. So if they have significant improvement after the ibuprofen and all these labs are normal, then I made a presumptive diagnosis of transient synovitis in that patient, because I've ruled out some of the more worrisome things. I've ruled out some type of leukemia and malignancy, and the SED rate CRP normal. I've ruled out a lot of the infectious causes or the autoimmune causes. I've done the x-ray to rule out some trauma and things. So I've done a reasonable workup to make sure the child doesn't have anything really worrisome. And the ibuprofen is kicked in, and they're doing much better. So at that point, I send them home to continue ibuprofen around the clock for about 48 hours, have them come back in 24 to 48 hours to see if their patients, the symptoms have resolved. And if they have, then most likely it's transient synovitis. If things are progressing or getting worse, and worsening of fevers, worsening of symptoms, then they have to be seen sooner because they might have something else going on. So again, transient synovitis, most likely the cause of a child with a limp. So now let's see how our patient's case unfolded. So we had this 4-year-old patient that coming in with a limp that was worsening for 3 weeks, had this fever, and then had other symptoms, a bad rash, had a history of this eczema and ear drainage, and limping. So when our child came in, we did a little bit of a workup, and his CBC was totally normal. And we did a complete metabolic panel as well. Everything was normal on that. Because of his bedwetting history, we got a urinalysis, and that just showed a very dilute urine, but no signs of infection. Everything else was negative. And we did x-rays of that area of the tibia that seemed to be painful on exam. And it actually showed the patient had several lytic lesions in that area. And because of those lytic lesions in the tibia, the patient went to the OR, and orthopedics did a bone biopsy, and the bone biopsy came back positive and made a confirmatory diagnosis of Langerhans cell histiocytosis. So this patient had this disease process called Langerhans cell histiocytosis, and the lytic lesions in the bone helped confirm that diagnosis with the biopsy at that point as well. Langerhans cell histiocytosis is a very interesting disease entity. It's not that common, but basically what happens is that you get histiocytic infiltration in different parts of your body. And his symptoms could actually be explained, all of his symptoms can be explained by the Langerhans cell histiocytosis. So obviously the bone pain and the bone involvement was there, but the other symptoms that he actually had this bad eczema, and we know that the Langerhans cell histiocytosis, you can have histiocytic infiltration of the skin, and that can present with severe dermatitis and eczema that's refractory to treatment. So his skin findings and worsening eczema was actually part of his histiocytosis. And then he also had dilute urine and bedwetting, and actually had diabetes insipidus. and we know that you can have histocytic infiltration into your pituitary and into your posterior pituitary, causing you to have diabetes insipidus. So that was actually another manifestation of it, is Langerhans cell histiocytosis. Another component of that is you can have histocytic infiltration of your mastoid bone. So the fact that he had recurrent ear infections with drainage and mastoiditis was also his histocytic infiltration of that area. So a lot of his symptoms can actually be explained by his Langerhans cell histiocytosis. And this entity can present with a few other type of findings as well, in addition to diabetes insipidus and the mastoiditis and the skin involvement. Other things that it can do is you can have back pain. I've seen patients come in with back pain, adolescents and younger patients come in with back pain, and you do an x-ray and they have a compression fracture of a vertebral body because they have histocytic infiltration into that vertebral body. So you can see histiocytosis present with back pain as well. So I get very nervous about back pain in young children as well. It can also present with proptosis, so you can have involvement of the eye and the eye being pushed forward. So there's a lot of variations that Langerhans cell histiocytosis can present with that can be very concerning. And the thing that makes it even more disconcerting is that it presents with a lot of common findings that we see in pediatrics. Ear infections and drainage of ear infections, a common finding. Bad eczema that's not getting better, common symptom that we deal with. Bedwetting and enuresis, another common thing that we deal with. So sometimes these common things that we see can actually be manifestations of something underlying and something sinister. Histiocytosis is considered a malignancy, and many times you have to give chemotherapy for that to treat the Langerhans cell histiocytosis, which is what our patient ultimately ended up getting. And got better from the chemotherapy then. So this is the differential diagnosis and presentation of a child with Limp, and our child ultimately had Langerhans cell histiocytosis. I'm not going to give a full lecture on that. That's something now you can read about and look up on your own, and you can use this case to read up on and look up all these different things that we talked about on the differential diagnosis. Again, the focus of the CRASH course is related to clinical reasoning and analytical skills, going through the differential diagnosis, and then thinking about things on the differential, and then using it to then read about those diagnoses on your own. So thank you for watching this case today about a limping child and the differential diagnosis and the presentation, and look forward to seeing you viewing other CRASH cases in the future.